This meeting is being recorded.
Okay. We can get started.
Well, thank you very much, Angela. My name is Vic Kashup, and I'm really thrilled to join this phenomenal panel on a very important topic, something close to my heart, and I'm sure to all the participants in this webinar. And I think the good news is at the end of this, we're going to have some time for great discussion, I hope, between the panelists and also from all of you that are joining us. I'm joined by my colleague, Greg Casper, who's the president of the Jobs Vascular Institute. And let me turn it over to him to introduce our first speaker. Thank you.
Yeah, thank you, Vic. And I couldn't agree more. And certainly like to thank the Midwest Vascular Surgery Society and the Education Committee in particular for continuing to set up these webinars. They've been a great success for us so far. Couldn't do it without our sponsors. I'd like to thank BD for their sponsorship. These things wouldn't be possible without them. And certainly like to thank our panelists for starting. We're going to start off first with Dr. Lindsay Karepta, who is an assistant professor in surgery at Loyola Medical Center. Lindsay, thank you for joining us. She joined Loyola in October of 2020. And prior to that, she was employed at Brigham and Women's in Boston, as well as Cape Cod. She joined there after completion of her integrated fellowship at Michigan State, and her practice includes the full gamut of vascular surgery, like many of us, but obviously a lot of that clinical interest is in treating peripheral vascular disease with both vascular and endovascular techniques. So Lindsay, very honored to have you, and thank you, and look forward to hearing you.
Absolutely. Thanks, Greg. Happy to be here. I'm just going to go ahead and start sharing my screen here. Please let me know if you can't see or can't hear. Okay, so starting off, I am going to talk about the role of atherectomy in treating PAD and CLI. So talking about the types of lesions and the types of devices. I have nothing to disclose other than I'm not an atherectomy expert by any means, but I do have quite a bit of experience in it. So in ways of overview, we're going to look at the role of atherectomy, the type of lesions that I use it for, the type of devices that I'm most comfortable with, case examples, and then some special considerations and pitfalls. So the types of lesions that I start to think about using atherectomy are particularly areas where stents fail, especially in patients that aren't bypass candidates. That's sort of the algorithm that I use for myself, at least. A lot of types of atherectomy, and we'll go into detail with the different devices, are very good at hard, eccentric, severely calcified plaque, but there are some on the market that are good at mixed morphology as well. I particularly start to think about atherectomy in areas where stents have proven to have difficulties and difficult long-term patency rates. And this would be in areas such as tibials, pedals, flexion points, such as the common femoral, SFA, or popliteal, and areas that have difficult retreatment of stents, so in-stent restenosis. So we'll go through the different types of devices, but just general categories. They fall into directional, rotational, orbital, and laser atherectomy. You can see some schematics on the right here. So in breaking it down, the first category, directional atherectomy. So these are all related to each other. They're all made by Medtronic. Silverhawk is the oldest of them, and then they came out with TurboHawk and Hawk 1. I personally use Hawk 1 quite a bit, actually, and I really do prefer it when I'm doing tibial work. There's several different reasons for that, but I feel the most comfortable when I'm able to use distal embolic filter protection. So that's something that we'll talk about in the additional slides to come. But Hawk 1 has a nice low profile. You're able to actually pack the nose cone without having to remove it. Older devices, you had to remove it to unpack it. But going forward, it has 3 different sizes. They're small, medium, and large. So these are located all the way down into the tibials and into the pedals as well. So broadly, the advantages of directional atherectomy really are that it's, for targeted eccentric plaque removal, and it's effective in severely calcified lesions, but I've also found that it actually works fairly well in mixed morphology. I would not use this in any sort of an acute thrombus or something extremely soft, but in a mixed morphology, it's done pretty well for me. Disadvantages, it does have some element of vessel wall trauma. It can be time consuming. The newer devices, I think, are less time consuming. So here's just kind of a picture of one of the different nose cone models that they have. So this is the Silverhawk here. We'll go through because I think it's hard to even kind of describe some of this. I'm sure many people on the call are familiar with atherectomy, but in going through and looking at this is that side cutter in the back. So actually it has a long leading nose cone, and that's what you're going to pack the plaque into. So here they show that you're actually removing, debulking, and you do it in a directional fashion. So you would do one pass, pull back, redirectionalize it to either 180 degrees or 90 degrees, kind of depending on what the lesion is that you're looking for. I found this actually can decrease your risk of embolization by actually choosing exactly which direction you want to atherectomize, trying to keep the device and the debris away from single vessel runoff, things like that. So I'm going to keep going forward in the interest of time. Here's some real world examples. So just some intraoperative cases. This is the Hawk one. So this is actually a case that I just finished the other day. So directionally orienting it. So it's really kind of a 2-operator technique where you have somebody that is holding the catheter advancing, and then you'll have your cath lab tech usually, or maybe trainee helping do the button, which they're showing in the picture on the right there. So you pass, and then you pull back, and then you are able to actually pack within the nose cone. So we won't watch the whole video, but we'll keep moving on. So just some pretty pictures. I think, a lot of the devices will have published some of these, but a lot of these are from things that I've done in my hands. So severely calcified, CTO, extensive collateralization, really eccentric hard plaque. And I think that there's a really nice result here. This was used in combination with the DCB. Down in the tibials, I am getting a little bit more into this in my practice. I've really expanded over the last couple of years, and I really do enjoy doing atherectomy in these really calcified vessels where the patient is not any form of distal bypass candidate, or maybe they don't have a great distal target, or they're non-ambulatory, kind of people that aren't going to be a great setup for long-term success with an open repair. So here you can see this is an anterior tibial that was severely calcified. It had a couple areas of CTO, had a really nice result on the right. And this was just with regular balloon angioplasty at the end. So kind of same thing. I feel like a lot of us that practice in areas where there's a lot of diabetes, a lot of heavy calcific disease below the knee, there's not a lot of other great options. And I've been really impressed with this device. These are all Hawk 1 photos. So going kind of into the next broad category, we have rotational atherectomy. So these are more of the front cutting devices. So you'll have your rotablator, your Jetstream, the Phoenix device, Rotarex. They sort of all fall into this category. Again, these are very effective in severely calcified lesions. They do have active aspiration, so that kind of differentiates it from the directional, and they do rotate very fast. But you can't modulate the depth of the atherectomy with these. And because of the front cutting, they don't take turns very well, as sort of what I've discovered. So areas with a lot of tortuosity, or in a patient that has a really steep aortic bifurcation, these don't tend to do as well. But again, here's kind of just a quick video of how it works. So you get it in a position, there's that front cutter that introduces into the plaque and does this active aspiration. So it actually is pulling that plaque up and into the device itself, catching it so it doesn't shower distally. In the interest of time, we'll keep going here. So you can use any of these methodologies in conjunction with IVUS, which I really do like doing. I think it gives you a lot of important information. So here is IVUS pre-rotational atherectomy, and then post on the other side there. Again, it's not 100% open, but you've created a channel. Likely it's enough to hopefully get their wound sealed, kind of get them out of critical limb threat. And again, a lot of these devices will have sort of the pretty pictures, but it down all the way down into the tibials, very small diameter vessels. They are safe, they are effective. You can get a really nice result, as you see on the screen right there. So orbital atherectomy as the third category we're going to talk about here. So the Diamondback really is the largest member of this orbital atherectomy family, and that's the eccentric diamond coated crown. And then the atherectomy depth can change on these. So you can get a little bit deeper with increasing speed. And again, these are very effective in severely calcified lesions. And the atherectomy modification is nice on this too with the different speeds. However, you cannot do this for in-stent restenosis. You can't do any of the last three that I've mentioned for in-stent restenosis. It's not recommended. So this is the bore, if you will, and sort of rotates and sands as it goes along. So just a quick video again, so we don't have to describe the mechanism of it. I think a picture says 1,000 words with these different devices. But here it's, I almost think of it as like a sanding, a rotating 360-degree, almost sanding of the inside, purposely embolizing, but very, very small little pieces when you're doing this. The idea is they're so small that they shouldn't cause any distal runoff issues. All right, and so we'll keep going here. So orbital atherectomy, sanding down these large, heavy, calcific, eccentric lesions. These are a couple of pictures from my patients. Again, not 100% perfect, but much, much better. And again, these are kind of high risk patients in general. I do like this CSI atherectomy, especially with these coral reef plaques, almost these really, really calcified kind of really ugly looking, for lack of a better word, lesions. You can see a really nice result on the right, and that was with just a balloon at the end, no stent. Kind of the same thing here, so we'll just keep moving. So laser atherectomy is kind of the last member of the big family here. So these I do use quite a bit actually in my practice for in-stent restenosis. So they're safe for in-stent. They don't have the metal, the turning metal, things like that. I use this in conjecture with IVUS quite frequently. It can take a lot of passes, so it can be quite time consuming, but I think you can get a really nice result with in-stent restenosis. And it's kind of one of the only tools that we really have for that. So here's one that there's no stent involved with a really nice result kind of in the SFA. This was one of our patients that just, I inherited that had really long segment of stents, and we were trying to keep these open. She'd had them for years and years. So doing some laser atherectomy to kind of clean out that lumen with a little bit of gentle ballooning. This is one of those patients that just has really, really small vessels and challenging to keep open. So in the sake of time, I'm going to start going just a little bit faster here. So special considerations. I personally really feel much better doing any of these atherectomy devices with distal filter protection, particularly if there's only a single vessel runoff. You're always got to be thinking about the potential for perforation, taking the tortuosity of your target into account, and then steep aortic bifurcation. So you do risk embolism. Really, that's not as much of a concern with air when you're in the lower extremities than if you were using one of these up in the carotids. There's different types. The spider is probably the one I use the most. So it's deployed over its own wire. I think this is a really nice reference. So I'm just putting it out there for anybody that wants to do a little bit more reading, in-depth diving. They did this study where they looked at Silverhawk, Jetstream, and Turbo Elite. They used both spider or NAV6. So each one of these patients got atherectomy with a distal embolic filter protection. And then they took the filters out, they did microscope evaluation, and they found that actually 62% of these filters did contain macroemboli. So they weren't clinically significant because they were caught in the filter, thankfully. They didn't see any difference in the rate between the different device types, but the overall recommendation from this paper is really start to think about using a filter if you have a CTO, if you have in-stent restenosis, if you have thrombotic lesions, or if you have a calcific lesion longer than 40 millimeters, or if it's an atherosclerotic, more of a mixed morphology, greater than 140, and you only have a single vessel runoff. So I'll just put that plug out there. And so this is actually an ancel sheath that we walked the Phoenix out through the ancel sheath, and it actually fractured it right in half. And we had to go back in and retrieve the other half of the ancel sheath. So these are not without, I don't know, you've got to really think about the anatomy of the patient before you put these in. So I think the aortic bifurcation was just a little bit too steep. And then this particular atherectomy device was just a little bit too firm for going over this bifurcation. So always something to be wary of. So I will end there. And I think that we are taking questions from what I remember. I'm happy to answer any questions that you have in the chat, or feel free to reach out by email as well.
Oh, thank you very much, Dr. Krepta. I believe we're going to take questions at the end. Angela, can you confirm that?
No, you can take questions now first, after each talk.
Okay, wonderful. Well, let me start this off, and for those of you, you can use the chat function as well, and we can ask those questions for Dr. Krepta. Can you tell us, whenever we look at luminograms, they're two-dimensional, obviously. How do you gauge the direction for directional atherectomy?
That is such a great question. I like IVUS. I use a lot of IVUS actually. And with the directional, I'm always cognizant of where I don't want to shower something. If there is going to be distal embolic phenomenon, if there is a wide open AT and I'm trying to do maybe an atherectomy into a tibial perineal trunk because the person has a heel ulcer. I just had this case actually earlier this morning. You can directional, so you can move your actual cutter away from that AT. Encouraging, if anything is to embolize, to potentially go straight down. And that's usually where I'll park my filter, is kind of the straightest vessel, thinking that that's where the emboli are going to go. That's not always the case, but it has worked pretty well for me. So IVUS can be a powerful tool, or just taking multiple views, taking a couple of different angiograms and different projections. Some of these patients will come to you with a CAT scan, but I don't always get a CAT scan. So I think that we have powerful tools that we can use on the table at the time to make those decisions.
I have a quick question for you. Thank you for that wonderful presentation. My personal sort of principle has been, if you can't dock an EPD, don't do atherectomy. So in some of the cases you were demonstrating shows, 2-millimeter tibial arteries that you're shaving plaque from. So how do you protect that patient from any distal runoff issues post your intervention, especially when you're dealing with these almost circumferential calcium and extensive long CTOs in these tibials that you're showing there? So how do you protect yourself from any event?
Yeah, another great question. I think you have to have a healthy fear of some of these tools, right? They can be powerful, but when it goes wrong, it can definitely go wrong. So I go slow, very slow. Whenever I'm doing atherectomy of any form, even with CSI, I'm flushing a lot in between the different runs and going nice and slow through that plaque and then coming right back out nice and slow. I think patience really is a virtue when it comes to atherectomy. You want to get through it, make it better, go on to the next case. But if you really go slow, take your time and, really have to think about these cases and preoperatively plan for the anatomy of the patient and the different type of lesion that you're dealing with as well. Inevitably, if you do atherectomy, you will have some embolic phenomenon at some point. So then also, having the appropriate tools to deal with that. But I think if you just go low and slow and you think about the different type of atherectomy devices, you can avoid it.
Lindsay, along those lines, and great talk, by the way, thank you very much. I think we all agree when you've got limited and compromised runoff, we're going to err towards the side of using distal protection. We've kind of established a go-to with the NAV6, mainly because we've used a lot of rotational atherectomy, and with the previous generations and issues with wire stick, that was obviously for not being too crass, but very sphincter tightening, as you can imagine. But what caveats do you use in certain situations where your runoff is maybe okay, but are there certain plaque morphologies that you will always go to an embolic protection device because of concern about embolism?
I try to use one, honestly, whenever I can. Just because I've done a lot of these, I've done a lot of the different types, and you kind of read about them and, oh, they have a low rate of embolization, but you are going to see it at some point. So I try to use it as much as I can, to be completely honest. So the devices where you can't use distal embolic filter, like CSI, they want you to use the spider wire because it kind of moves so much that they really don't want any wire wrap. So they want you to use sort of the long metal wire that they recommend. So I'll use that occasionally in really eccentric hard plaque with good runoff. If there's any kind of bad runoff or single vessel runoff, I will only use a device where I can use distal embolic filter protection. And again, giving the caveat that these are not necessarily bypass candidates. I sort of, would do that first for anybody that has a nice vein, a nice distal tibial target. These are people that don't have those options, and you're kind of trying to keep things open as long as you can to see if we can get these ulcers healed up.
Well, thank you very much, Dr. Krept. Quite frankly, we could spend another hour on this topic because it's so fascinating. Thank you for your presentation. But let's move on, since we've got 3 additional phenomenal speakers. We did have a change in our schedule, and we're so happy that Dr. Natalie Weger stepped up to the plate and is filling in on our next talk. Dr. Weger is a clinical associate professor of surgery at the University of Iowa. She's also the co-director for the general surgery clerkship at the Carver College of Medicine. We really want to thank her for stepping up to the plate and participating. Dr. Reger, all yours. We can see your slides, but you may be still on mute.
Yes,
Great. Can you hear me now?
yes, thank you.
Great. Sorry about that. Like they said, I'm Natalie Bager. I'm happy to present today about the task I was given, which is the prevalence of mixed morphology in plaques as well as in PAD and thrombus in PAD lesions and the need for atherectomy in combination with aspiration. Thrombus is present in femoral popliteal native arterial occlusions in about 27% of patients. And in restenotic lesions of all types, with or without calcium, it's present in about 50% of lesions. For acute limb ischemia, we think that embolism is causes the occlusion about 42% of the time and thrombus in about 26% of the time. Histologically, the chronic total occlusions contain fibrocalcific tissue, atherothrombotic soft tissue, and thromboembolic tissue. There's also organized thrombus, fibrotic tissue, and calcifications. In reality, most of these lesions usually have some kind of soft core, and less than 10% of all PAD lesions have a severe intimal calcium burden. The calcium has been suspected to be a cause of the lesion and radiographically on imaging for about 89%, but when we studied it histologically, it's only present at about 3%. And thrombus was suspected in 8%, but histologically, it's present in about 52% of the time. So hence the need for maybe a combination device. This was the data that was given to us and shown to us at Sharing Crossing in 2019, as well as the histology information was from Rosenheim in Germany, as well as Leipzig in Germany and the Czech Republic. So this case is one of mine, again, an atherectomy case. It's the SFA and one in the popliteal. I performed these for chronic limb threatening ischemia. I did use the HawkOne device, again, with a spider wire protection embolic device as talked about in the previous slide. And I had a decent result, but what about the cases where I didn't have a decent result, or I suspected there may be more complications with distal emboli or thrombus, or the ones we get caught where we didn't anticipate it, like this one. As we know, not all CTOs are the same. Some we prepare for and need distal embolization. We know that there may be an issue. Many of us have adopted a treatment combination and or planning for bailout. For instance, using the embolic protection devices routinely or with single vessel runoff at least, having backup skills and equipment available. And those may include suction embolectomy catheters, pharmacomechanical thrombectomy, bailout, operative open plans as well. In 2020, I did this case for one of my senior partners, and as a great thank you, I embolized his only outflow vessel, which was an anterior tibial vessel. So that was not my finest moment, and I spent several minutes trying to improve the flow and return it to what I thought was more of a suboptimal disease state. However, the patient went on to do well, and at that time, I got inline flow back using a variety of techniques of TPA, suction thrombectomy, and angiojet mechanical thrombectomy. But in hindsight, I think I may have been better suited, if this vessel is at least 3 millimeters, to use one of the newer atherectomy devices. And as we just heard, Rotarex has been FDA approved since March of 2018 and may have been a more appropriate device since it has an atherectomy and a thrombectomy indication. The previous speaker already went over all of the fine points of these different atherectomy devices in a excellent fashion, so I will not repeat that in the essence of time. But I will go on to say that percutaneous devices have been used to treat chronic limb-threatening ischemia, acute limb-threatening ischemia, primary and secondary assisted patency of previous interventions, and patients with native calcifications and lesions for PAD for about 17 years, not only in the outpatient lab, inpatient and outpatient setting, but most of the time we have to treat them in conjunction with other devices such as planar balloon angioplasty, drug-coated balloon angioplasty, bailout stenting or selective stenting, aspiration, or even open salvage techniques. For more detail about the Rotarex device, which is a BD product, it was made in Switzerland by Straub. That company has some interesting history, but they developed this Rotarex device in the 6 French and 8 French sizing. The 6 French comes in 110 and 135 length, and the 8 and 110 and 85. There's a nitinol core guide wire that comes with it in the kit. It's an 018 system. You will have to cross the lesion on your with whatever crossing wire you like, and then switch over to this type of wire. The wire also has a hydrophilic outer coating, but it is not really recommended to use a different wire with this device. Some of the kits will come with a backup wire in case something happens. The gold tip makes it easy for visualization. The rest of these devices were talked about by the previous speaker. So there are 2 devices, though, that are on the market that have this rotational atherectomy and aspiration. The other model of Jetstream has these blades on the outside, and the newer, well, a couple years old now in the United States one, the Rotarex has the blades on the inside of the device, so that allows for us to use it with in-stent stenosis. The blades are protected by this other outer core and therefore will not injure your stent. There are possibilities for re-entering the arterial chronic total occlusion and forming a dissection. So that would not be a candidate for this type of device. It is not also very useful in calcified vessels, the ones I had talked about, which is about less than 10% with calcium throughout the whole lesion in the intimal layers. It can treat vessels between 3 and 5 millimeters. So you're right, with the distal tibials, it's not a good idea. And that did show some perforation of vessels. And like you said in the other discussion, that there's no great bailout for that. There are large vessels that can be treated typically between 5 and 8 millimeters in size, and you'll want to use the 8 French device for that. The IFU for this device sets it's intended as an atherectomy device with thrombus retrieval for our upper and lower extremity native vessels, peripheral arterioles, peripheral arteries with stents, stent grafts, or native and artificial bypasses. Because it's the rotor blades are protected and on the inside of the device, you have a continuous suction and removal of debris, but without injuring maybe your vein bypass, for instance. It is not intended for the use in the coronary, carotid, pulmonary, or renal vasculature. And the difference between the 2 devices not only are the rotational blades, but the aspiration port is quite small on this device versus the huge, more aspirative, large bore on the other device. It also comes in a slightly smaller French. There are several studies that have compared modalities of treatment for peripheral arterial disease dating back to the STYLE trial in 1994, where they compared thrombolysis versus surgery, and those are the outcomes listed. TOPAZ trial, again, thrombolysis versus surgery, and it looks like On that trial, the surgery was less effective. And then there's a bunch of retrospective, independent trials on limb salvage for Rotarex. These I can go into in more detail, but there has been subspecialty training in Leipzig, Germany. And because the device was made in Switzerland, that device has been in Europe for many years. We've only had it for a few, but they've studied it extensively. People have even gone on to leave Germany and move here. And there is one such person at Baylor College of Medicine that's now the head of limb salvage program. That person was quoted as saying they use this device in a primary fashion instead of as a backup type fashion, or only for those who are compromised or don't have a bypass. I don't feel like we're there yet in the rest of the United States, and I'll go through why. But their experience is extensive, and I have the references if anyone is interested. So the first one in Leipzig, Germany, and it's fitting that I'm the speaker for this because I was born in Germany and appreciated and got a little nerdy in finding out all my colleagues doing this work. But the atherectomy device that they used, they treated acute, subacute, chronic occlusions, in-stent stenosis, thromboembolic disease, in situ thrombus formation with COVID-19 infection, which I found really interesting. As we've all probably experienced with COVID infection, that this thrombus burden is slightly different, more sticky, very difficult to open up with open thrombectomy. And I would really be interested in learning more about this myself. And then bypass thrombosis. So there is the 8 and 6 French system I talked about. What you do is you cross your lesion, get your sheath in, change your wire out, and use their device. It hooks up easily to itself. You have to put a sterile cover probe over the gun type handle. And then that part is non-disposable, but the rest of the device is disposable, and you easily hook it up to a very small machine that's about the size of a shoebox. You perform the device thrombectomy by a to and fro fashion, and you want to leave the end core in place or present until you pass about 2 or 3 times through the lesion. They treated long lesions up to like 14 centimeters in the trials, as well as some that are even longer in some of the trials I've mentioned. So the atherectomy device kind of came from this. In the background of the slide, you can see that concept of the larger mechanical means of how they've discovered it. But they did 658 procedures in 12 months, and they found clinical success initially at 78%. They even had challenging lesions. Like I said, they were long in length. They were calcified about 50% of the time, and the patients were in trouble. They were Rutherford chronic limb occlusions, chronic limb ischemia of 4, 5, and 6 class on admission. They were also treating chronic lesions, so they didn't go for the easy, short, small lesions. This was presented previously at Charing Cross, like I stated. The patient had a little example of a chronic total occlusion and really no outflow. They did some passes with the device and were able to restore inline flow. They compared their more studies too in Czechoslovakia with their Rotarex trial against the Topaz and Style trial, as well as Rochester trial, and had excellent results. They did use mechanical thrombectomy as the first line treatment in patients, and found they had sometimes distal emboli for which fibrolysis overnight resolved it. They did require about 5% of rescue open surgery, 2% amputation rate was seen, and 0.0% death rate. What's interesting about this is this was slightly further down the road with some improvements in the technology, and as well as usage and appropriate selection. Again, these are all retrospective single center studies. This is from France. It's one of the independent studies that they showed, but the bottom line is that they were also able to get a successful inline flow when the patient had no distal target. They started using the subacute arterial instant thrombotic occlusions to treat them with this type of device. And they were successful in restoring flow using the Rotarex. And typically they used a plain old balloon or drug-coated balloon for completion and got inline flow there. There's been several more papers, and in the essence of time, I will go over it quickly. The last one caught my eye, but the first one is from China, and they wanted to prove safety using the Rotarex for femoral popliteal and stents chronic total occlusions, for which they did, and they were successful at 94% of the time with a combination of a drug-coated balloon. In Poland, they worked on using Rotarex and drug-coated balloon to treat chronic total occlusion in stent iliac and infrainguinal arteries, and they were successful 98% of the time. The next one in France, they used the Rotarex. They had a technical success of 98%. They also used the drug-coating balloon, but not as often. They used plain old balloon more commonly, and they had a 12-month success and patency rate of 92%. The last one I like just because of a personal history. The last one is from Ingolstadt, Germany, where I spent many of my young years. My brother still lives there and is a child psychologist, which does not add to our practice here, but I found it very interesting that they are doing this type of work. And they published a study in 2019. They did 156 acute infrainguinal ischemic events in 148 patients. They were all in the Rutherford class of 1, 2, or 2B. The most common were in the Rutherford 1 or 2A. They had occlusions that started at or below the knee joint in about 40%, and the rest in 60% were above the knee. They used the same basic techniques of simple aspiration. When that failed, they went on to use the Rotarex catheter system and were successful in saving technically the limb at 93%. They had some complications that then required additional things like directional atherectomy. Treatment for downward embolization was only seen though in 11 patients and 4 surgical groin revisions. 5 patients died in early follow-up, but 4 were not related to intervention, and clinically 86.5% showed improvement in their clinical situation with, again, this is treating acute infrainguinal leg ischemia. So unfortunately, this has not been adopted as a practice to use here for acute limb ischemia. And the Journal of Vascular Surgery in February of 2020 issued a long review, a meta-analysis that was out of the Netherlands that stated that the endovascular and surgical revascularization techniques in acute limb ischemia do not have enough data really to recommend this as a standard of practice. They had complaints about the use of this device in the common iliac artery, stating that not all thrombi could be removed, and there was therefore a significant number of stent graft placement. The company, when I spoke to them about this concern, said that they probably would have benefited from doing more passes instead. And again, I think this device is newer to some of us than others experienced in Europe and in Germany in particular, France and Czechoslovakia. But they recommended that we use more data to find out the exact role of angiojet or Rotarex devices to treat acute limb ischemia. And this was at the time of publication, which was in, again, like I said, a couple years ago. They did, however, admit that Rotarex had less length of stay and less major vascular events compared to TPA alone. So in summary, we need the right tools for the job and to continue our efforts to develop future trials for our PAD patients. And I wanted to thank you for your kind invitation.
Dr. Weger, thank you very much for that very well done and comprehensive evaluation of a complex and I think still evolving topic as far as especially related to morphology in that area and the role of thrombus in that area. In the interest of time, I'd like to, if we can, hold off on questions regarding this talk till the end so that we can kind of get through all of these speakers in an appropriate and timely manner. So with that, I think we'd like to move on. Thank you very much, Dr. Weger, and please, everybody hold your questions for the end in that capacity. And we'd like to introduce Dr. Cheong-Jae Lee, Clinical Associate Professor of Surgery at the University of Chicago. He is also Section Chief of Vascular Surgery at North Shore University Health System. He attended the University of Michigan Medical School and General Surgery Residency. Yes, go Jobs and go Michigan. But that was for our Ohio State brethren in the society as well. He also served as an associate professor of surgery at the Medical College of Wisconsin for several years as well. And he's got, I think, an interesting interest in topic in genetics risk scoring for assessing aortic aneurysm and PAD as an area of interest, and obviously also has a lot of clinical interest in treating open and endovascular interventions for the management of not just aneurysms, but PAD. He's going to talk on atherectomy and anti-restenotic therapy for treatment of PAD. So thank you, Dr. Lee, and I look forward to hearing your talk.
Thank you very much for that kind introduction. So we'll go right ahead on my talk, atherectomy and anti-restenotic therapy for treatment of PAD, especially in the presence of in-stent restenosis. I have no financial disclosures, but I will be discussing the off-label use of atherectomy device. And I will note that I rarely treat in-stent restenosis these days because stenting has largely fallen out of my personal practice. Now, when you're thinking about atherectomy, embolic protection is essential. We've talked about it with the other speakers here, but regardless of what device companies may tell you, all have certain embolic potential. And I avoid atherectomy actually in very heavily calcified lesions for that reason. And avoid if there's no good place to dock an EPD, as I talked about earlier. Now I want to kind of couple of examples of this, heavily calcified lesions becoming a problem. There's a long day at the office picture on the right there. There was so much embolic debris after a atherectomy case of a heavily calcified femoral popliteal lesion to filter. I could not recapture it. It actually got stuck in the vessel. So I had to cut this down to get it out. So be careful when you're using atherectomy for these heavily calcified bulky lesions. Now, we know that stenting itself offers better patency rates that POBA alone has, but there remains a significant rate of restenosis up to about 30% a year. And studies report that longer the stented segment, the increased likelihood of developing significant in-stent restenosis. However, though my current practice for me has been provisional stenting, in challenging lesions, especially long CTOs, stenting is inevitable. Here, it's hard to leave a subintimal dissection following crossing the lesion without stenting. And invariably, these long CTO or stent cases will result in in-stent restenosis down the line. So brief pros and cons before we get to the meat of the talk on atherectomy for in-stent restenosis. I believe the real benefit lies in the luminal gain with the debulking for ISR. And usually technical success is good with good angiographic outcomes, making for very good pictures. But on the converse, I will review again that restenosis rates for ISR treatment is very high. There's also higher rates of distal embolization with atherectomy, particularly for ISR. So, outside of that, we do have to consider the device costs when deciding on debulking for these restenotic lesions. I think this slide is pretty self-explanatory. First pictured in that left CT scan is unfortunately a sheer disrespect for the common femoral artery and the profunda by a specialty who shall not be named. As a side, we are well aware of the saying in general surgery that you don't mess with the pancreas, but as a vascular surgeon, you do not mess with the profunda. And unfortunately, there are a lot of profunda molesters out there in the community, so be aware. In any case, you're looking at the Achilles heel of lower extremity interventions here, the intimal hyperplasia. Now, I took this stent out of that abused common femoral artery, and this specimen shows you that in-stent restenosis and intimal hyperplasia is a completely different process than de novo atherosclerotic lesions. Now, if endovascular salvage is considered, I think the best hopes of achieving any meaningful outcome is to reestablish the lumen by debulking. Trying to remodel this lesion any other way, save open surgery, I think will be limited, as you are fighting not only the confines of that stent, but this rubbery milieu that will recoil as soon as you angioplasty it. Now, many excellent studies have established the different biology of ISR and neointimal hyperplasia. And in this landmark report in Circulation, the primary molecular signature of in-stent restenosis is cellular growth and extracellular matrix, which validates the essential need and use of anti-proliferative agents to mitigate the occurrence of hyperplasia. Now, strategies of managing restenosis can be broken down to prevention or reintervention. Now, prevention is largely understanding and mitigating the risk factors for restenosis development, which include optimization of diabetes, provisional stenting and treatment of longer lesions or treatment of small vessels. And from a technical standpoint, inadequate stent expansion at the index operation is an issue. So, use of adjuncts, as Dr. Krepka, discussed, such as IVUS. I do like IVUS in almost every case as well. An appropriate oversizing of stents really may help in that regard for inadequate stent expansion issues. Now, there's pharmacologic modulation you can do around the time of the intervention, which include the index use of DCB at the onset of the lesion treatment, and the use of silastazole post-treatment, which in many reports have found to improve patency of these interventions. But if you do need to intervene, I believe the best is to debulk and DCB. As alluded to in the previous talks, there are many options for debulking, but I think no current device on the market was really designed for in-stent restenosis. Now, they may have indications like the laser and the Rotarex, I believe, which are the only ones that have that FDA indication, but again, they're not designed to treat it. In fact, many devices, including the device that I use most often, are actually contraindicated in in-stent restenosis. However, debulking ISR alone will have no effect on slowing the biology of that process recurring. Laser has some really good established data on the efficacy for restenosis, and there are also promising results, as mentioned by our previous speaker, coming out with the Rotarex device that has gained the FDA indication for in-stent restenosis treatment. But full disclosure, I'm sorry, this may be a slap in the face for BD, but I have been using the HOC1 device, the directional atherectomy device, for the bulk of my work, including for in-stent restenosis and other intimal hyperplasia cases. Now, as I mentioned before, and data shows, debulking itself is not a standalone therapy. As pictured here, most relevant in-stent restenosis case series show inferior TLR and patency rates without mitigation of anti-proliferation. There was a recent JBS meta-analysis that shed some light on debulking for in-stent restenosis. And again, alluding to the lack of quality data that's out there. Of 66 publications that this meta-analysis reviewed, particularly on in-stent restenosis treatment, only 12 publications out there had greater than 20 patients enrolled in their studies. So a pooled aggregate of 743 patients was established by this meta-analysis, but again, limitations on the clinical information on the indication for the restenosis treatment was absent. Now, the study grouped the patients into mechanical atherectomy versus laser, and the primary endpoints of patency and TLR were assessed and demonstrated, a ho-hum full patency, in my opinion, of 58%. and TLR of 66%. Now, mechanical atherectomy coupled with just PTA in comparison to laser atherectomy plus PTA really fared similarly. But what made the difference was the drug therapy, especially when laser atherectomy was coupled with drug-coated balloon angioplasty. They seem to have the best patency and TLR outcomes. Again, the big however is that distal embolization rates were really high with debulking for ISR, especially with laser with a risk ratio of 1.96. And there's literature that's upwards of 10% distal embolization rates with debulking for ISR with the laser. This is a recent case of mine to demonstrate the utility of debulking for intimal hyperplasia. Now, this is not an instant case. Nevertheless, this shows that debulking is an option, especially when open surgery may not be the most ideal initial approach in hostile anatomy. This is a 73-year-old male with history of an aortofemoral bypass, fempop, a groin infection, status post-gracilis flat. Now, this patient developed progressive right common femoral artery and profundus stenosis and surveillance in between the anastomoses there. So probably a combination of clamp injury along with intimal hyperplasia. So we accessed via a transradial approach, and we use an off-label directional atherectomy to clean this lesion and had a pretty decent result. So here's my 2-cent slide on a few tips on debulking in-stent restenosis with a directional device. Remember that this is off-label. First of all, when you're doing ISR treatment with the directional device, you don't engage the strut. So make sure that that cutting face of the device here is within the stent completely. And you want to mag up to see how close that cutter is to that stent frame. And you don't want to be too greedy as you pass the device. And usually I just do about 2 passes per direction. You want to make sure that the cutter is not engaging or getting too close to that stent frame. And obviously with every atherectomy case, I use embolic protection device. You want to anticoagulate well, and you want to DCB afterwards. But of all the devices I use for in-stent restenosis therapy, I believe, again, I put this up here because, I've had the most success with the directional in terms of actual luminal gain. The other devices were okay, but for the laser, I did have some distal embolization, which I did not like, and the data proves that. Again, these are my personal feelings overall on the atherectomy for different types of lesions. Again, this is completely my feelings. This is not evidence-based. I used all different modalities, and each type of device has their merits and issues. Certain devices work well for different lesions with different geometry of the plaque or different calcium makeup. Currently, I use the directional devices most often, as I have had a consistent success with it. So in summary, ISR biology is completely different, and anti-proliferative therapy is essential and is the difference maker, in my opinion. Now, myriad of devices are they're out there, but they're not for ISR, and not one is clearly better than the other. You want to choose the one that makes sense for you and you have the most comfort with. Again, despite beneficial outcomes, atherectomy in ISR has increased distal embolization risk, so EPD for every case. Thank you very much.
Dr. Lee, thank you very much. That was outstanding. There were a lot of unhappy faces on your matrix slide. That just shows you that we have lots more to learn and lots to understand in this area. But again, for the sake of time, we want to make sure that Dr. Bobrowski is able to do her talk. So let me introduce Dr. Trissa Bobrowski. She specializes in the management of complex vascular aortic and aortic conditions, but has really a primary focus on limb salvage. She's the director of the University of Chicago Limb Salvage Center and really provides excellent patient care. She also serves as the program director for the Vascular Surgery Fellowship at the University of Chicago, obviously wearing multiple hats, Trissa. So we're very pleased for you to join us and hear about your talk. Thank you. Take it away.
Thanks, Vic. And thanks to the New Horizons Program Committee for allowing me to talk a little bit today about pedal access, as well as for all these wonderful presentations that we've had today. As you mentioned, treatment of complex PAD is something that's near and dear to me. And I think that thinking about innovative ways to approach this disease process is really great. And to hear how other people think about it has been really enlightening tonight. So these are my disclosures, but the most important one is that I am not a pedal expert, but I have begun to use it more and more frequently and really truly believe it has a role in the vascular surgeon's toolkit. Many other interventionalists out there, such as cardiologists or interventional radiologists, have embraced this technique. And I think it's something that we've been a bit resistant to do as a group. And I think it really does provide a lot of very important options for a patient population that sometimes has limited options in general. So the scope of this is that as we have an aging patient population, as we have rise in diabetes and all of the other medical comorbidities that go along with tibial vessel disease, it becomes more and more difficult to treat below the knee. And we've talked about atherectomy and anti-restenotic agents and things like that today. And that's well and good for when we can get across the lesions, but we have to be able to get across the lesions first. And I think pedal access provides us an opportunity to treat below the knee in an innovative way. We look at this, and I think it's always shocking when the only thing that has a higher 5-year mortality in our patients is lung cancer. And so looking at ways that we can treat and intervene upon this disease process is incredibly important for this particular patient population. So why do we use tibial pedal access, and how can we think about employing it, and what situations do it work best in? So these tibial vessels are very, very small, as we know. And so there's just not a lot of space for things to go. So the small diameter actually oftentimes helps with the pushability. There also is less likelihood of entering a side branch or collateral. Since the side branches and collaterals are coming off in this orientation, if you're going perpendicular to it from this orientation, the wire and the catheter aren't likely to go in there. And so you can have more kind of a straight line access to the vessel itself. Interestingly, the hardest part of the occlusion to get through is often that distal cap. And so if you come from the opposite way, it oftentimes gives us the ability, it's softer on the posterior aspect of it. So it is very frequent that you just pop right through it. There's, I think, only been one instance in all of the pedal access cases that I've done where I have successfully entered the vessel that I haven't been able to penetrate that distal cap. So once you're in, 9 times out of 10, you're actually going to be able to get your wire to go past it. In cases of occluded short segment tibials or pop arteries, it oftentimes offers a shorter arterial segment to cross, considering coming from ipsilateral or contralateral approaches. We lose a lot of pushability. We lose a lot of momentum when we have to navigate tortuous aortoiliac segments or longer segments. And so if you have less that you have to cross, then it really allows you to get additional pushability. And again, I think about it, we've talked a lot about embolic protection devices today. In essence, you have an embolic protection device when you're down there in the pedal vessels or in the tibial vessels. And so if you have a small tibial and you're not able to get an EBD down there, then it allows you to have a little bit of safety there. Our obese patient populations or patients who have bypasses coming off their common femoral arteries, oftentimes we don't want to stick those common femorals in an antegrade approach. I'll show you a case where that was the case for me recently. And so it kind of negates the need to navigate complex or difficult femoral anatomy as well. And similarly, it may have a role in hostile or infected groins. However, these vessels do spasm. I'll talk about a way that we can try and prevent that. They can also dissect as well, especially when they're heavily calcified. Calcification can sometimes preclude our ability to actually puncture them. Many of us may have experienced that, and I'll show you a technique to try and mitigate that as well. And the closer to the ankle we get, the more difficult it might be to, from an anatomic standpoint, to kind of navigate the joint. So thinking about that is really key. So that really helps me segue into the most important part of all this, which is knowing the anatomy. Now, it may seem a little bit basic and a little bit redundant to say you have to know where your anatomy is, but it's really, really true. And it's really true, especially when we have branches that are coming off. And I say this, know your anatomy, because it's important to not only know, is your posterior tibial or is your anterior tibial open, but is it open in the vessel that you're trying to actually get into distally? So we can stick the anterior tibial artery here, we can stick the PT here, but if it isn't going to give you outflow to the foot in general, then it's really kind of a moot point. I also, in occasions, have stuck the lateral plantar artery. It's important to know if that artery is patent prior to doing that. But basically, anything that's open at the level of the foot or the ankle, or even higher up on the leg, is pretty much fair game in this situation. But if we're going to access it, is it supplying the angiosome of interest? Is it going to help you to heal your heel wound if you're sticking the DP? Thinking about that. And sometimes having preoperative imaging, such as an angiogram, is helpful in helping you decide that. The size of the vessel is very important. When we think about what size access we're going to use as far as our sheath size, we need to make sure we're going to be able to accommodate that. If you have a larger AT versus PT, that might help you decide which one of those vessels you're going to access. And the location of it, as I said, joints can be difficult to navigate. They can be a tortuous segment. Sometimes our only option is to puncture the perineal artery, and that can be a difficult artery to get access to, as well as to get control of after the intervention. So knowing that is very important too. You really want the maximal amount of unoccluded vessel proximally for support. So trying to access as distal as possible, but still in an anatomically feasible area is important. And also make sure that you give yourself room for a bailout bypass. You don't want to do something that you're going to cause a dissection or a catastrophic complication and then preclude the patient for having some sort of bypass procedure for limb salvage in the future. So how do I usually position these people? 90% of the time they can be done in supine. For whatever reason you think you need popliteal access to, you may want to consider altering that. The DP is best accessed with the patient's foot in dorsiflexions such as this, and then just a gentle rotation for supination is good for the posterior tibial access. I oftentimes am able still to do this with a MAC anesthesia, as well as a lot of local medication. And using ultrasound is really key. I cannot stress enough how important ultrasound is for this. Missed attempts may contribute to bleeding, compression, or compartment syndrome. I have never had that sort of complication, but I've certainly seen cases of it, and that can be catastrophic. So making sure that it is one stick, if at all possible, is really, really important. And using color Doppler or angio from above to ensure it's the actual named vessel is important too. Oftentimes we'll have patients that have a lot of collateral vessels that have developed down there, and you want to make sure that you're in the actual named vessel and not in a collateral, because again, that's not going to help you establish inline flow. So this is just an example of that. I find it helpful to look at it in both the longitudinal view as well as the transverse view. And that gives you a sense also of the amount of calcification and what your luminal gain is actually going to be. And do you have enough lumen at the area where you're accessing to be able to do that successfully? So you want to try and use the hockey stick probe if at all possible. For about the first 5 cases, I had one of our vascular lab techs come into the OR to help me, just because it was a lot going on and I felt like it was important for me to focus on getting the needle in and doing it well. So I had the tech come and she could help with the probe management. I don't need that anymore, so I don't have to use a tech to do that, but you may find it helpful initially. It's also important to make sure you're using the correct probe. What you're really looking for is definition and not depth. And so that's why I use the hockey stick probe or a smaller probe to be able to do that. Again, it's really important to access it on the first attempt if at all possible, because these arteries are very prone to spasm, and then it can make it difficult to get access. And then you have a situation where you're kind of marching up the leg more and more and preventing that additional length that you need to really get a running start for your interventions. And usually we think about using about a 60 to 75 degree angle to enter. And if through and through, it's really easy. All you have to do, and if you're watching this under ultrasound, it's very easy to see that you've gone through and through, and you can just watch as you withdraw your needle to achieve access. Frequently, these aren't aggressive back bleeders, so it can be difficult to tell if you're in. It's almost akin to sticking a vein sometimes. So being really thoughtful about it, and even if you use like a little TB syringe or a 3cc syringe to aspirate with, can also be an adjunct that I found helpful in the past. So this is an image of the artery going in, and you can see it longitudinally here. It's not a perfect picture, I apologize. We did this the other day, but you can also see the wire here. And that's another really important thing, to watch your wire go all the time too. So calcified vessels can be very difficult to access. One technique that is helpful is if you use a lot of local anesthetic, it kind of acts as tumescence and it stabilizes it, because these are very small spaces. There's no place for that artery to roll. And alternatively, we can use this buddy needle technique. And this is especially helpful in cases of multiple missed attempts. So what we do with that is you can see if you have accessed on the side and you have missed, but you have a needle there, what that's going to do is that's going to help stabilize your vessel from rolling laterally then. So if you have the vessel stabilized against the needle here, then you can enter it anteriorly and get access. You can also actually do it where you, and they talk about a chopstick approach, where you have double needles, one medially and one laterally. And then there's really no place for that artery to go. It's really fixed between those two rigid supports. And then you can oftentimes just get your needle in anteriorly, and that's helpful too. So if you keep on seeing the needle bounce off time and time again, go ahead, accept it, just put your needle there and then get a new fresh needle and access it anteriorly. So as I said, I always watch the needle go up. I do that either with fluoro or under ultrasound. It is incredibly easy because you do have the two paired veins there, and these arteries can be fragile and friable to actually cause a perforation, and you're within the vein before you know it. So watching that is really important. And also really using slow injection of contrast is important. You're not in the iliac, you're not in the common femoral, you're not even in the proximal pedal vessels or proximal tibial vessels. You're in a very small, very fragile artery. So be very gentle and very judicious with the injection of the contrast, because you can cause extravasation just by injecting contrast as well. So I really find that you have to have a good pedal access kit, and the wires and catheters that accompany that are a must to be able to ensure that you're getting access in a manner that's safe and consistent. So the way that I do that, many different companies have different kits. I happen to use the Terumo kit here. You can see it comes with a small access needle. Sometimes this needle is helpful. Sometimes I just go ahead and use a traditional micropuncture needle to get in. It just kind of depends on the anatomy in the vessel. But regardless, once you're in, then there's a wire that accompanies this kit. which has some stiffness and stability and allows you then to go ahead and put the sheath. You see that the dilator for this sheath is relatively long in comparison to the sheath. So sometimes it's important to be aware of that and actually telescope the sheath over the dilator as well. So getting familiar with the kits, understanding how to use them is a key of this as well. But I happen to find this pedal access kit very helpful too. So there are a bunch of different ways that you can think about this. Once you have access, in my experience, you don't need a lot of specialized equipment to then do the intervention. Frequently, I go ahead and use my traditional glide wire, glide catheter, or if I want to use an 014 system because I know I'm going to be using an 014 balloon, then I just go ahead and start out with an 014. But if you know that you're going to do something that's a little bit more complicated, for example, if you're treating a fem-pop lesion and you're intending to use a drug-coated balloon and you know you need a 6 French sheath, then make sure that you try and limit the amount of time that you have a larger sheath size in. Oftentimes, if you want to do that, then you can consider coming from a femoral approach as well. I think more and more people are kind of getting out of the habit of also having femoral access. But if you need to, or if you feel compelled to do that, to be able to snare the wire and then have through and through access, so then you can do larger interventions from an antegrade approach, then that's totally fine as well. It just kind of depends on the comfort level. I've done enough of this that I'm pretty comfortable doing things all from the foot or from the ankle. But if you're more comfortable using a femoral approach still and doing things antegrade, once you've gotten across the lesion and snared the wire, then that's totally reasonable and acceptable as well. And sometimes I've also done just completely sheathless. If I'm trying to keep everything very small, or if I know I don't want to upsize, then you can go ahead and just actually advance the balloon over the wire from the foot itself, and you don't necessarily need the sheath. Vasospastic cocktails, there's a lot of kind of debate about whether or not they're necessary. I have always used it. I learned this technique from our interventional cardiologist, and I use the same cocktail that they use for a radial approach. So it's 3,000 units of heparin, 2.5 of verapamil, 200 micrograms of nitro, and that's in a total of 5 cc's. Usually I don't feel like I take that long for the intervention that it needs to be redosed, but I also do give a low dose systemic heparinization as well. And so then, as I said, femoral access can also be an important adjunct for all of this. So what's the experience? There's not surprisingly a lot of good data out there looking at this.
Dr. Bobrowski?
Yes.
I'm so sorry. We're running really over and we want to make sure we get to questions. Could I please kindly ask you to maybe wrap up in a few minutes, and then we can get to some questions that the audience may have. Thank you.
Sure. So just to kind of look at this quickly, experience is good. People who are adept at this are oftentimes successful in completing their therapy. I'm just going to show one example here. This is a patient of mine with bad tibial vessel disease after 20 years on dialysis, who I had taken from an antegrade approach and was successful in getting a wire pass, but just couldn't get any pushability to perform any sort of intervention. So I brought her back, was able to get in successfully from the foot, as you can see here, and then you can see she has an intact pedal arch. And from this access was able to actually go ahead and perform my intervention. It was much improved after the intervention. You can see this was pre-op, no flow noted in the DP, and post-operatively, she had a biphasic waveform with improvement of pressures. Just another quick one, somebody with a bypass who had occluded outflow, probably from a clamp injury, had a occluded iliac on the contralateral side, and with the bypass coming off the common, I came from the foot. You can see I was able to cross the occlusion, get into the bypass, perform a balloon angioplasty, and was able to salvage this bypass. So Along with everything we've said, the most important part for this is really patience, patience, patience. There is a learning curve to this. It does take time. It does take a lot of preoperative planning to be successful in doing it. But I think that when done well, it's well worth it. So I will stop.
Thank you so much. That was outstanding. We've got a few minutes for questions, so the participants, please use the chat function, and Dr. Casper and I will ask questions. Dr. Bobrowski, since you have the virtual microphone, let's start with you. Perineal artery access. I've done that really only a couple of times when there's a large collateral over the lateral malleolus. Any tips or tricks on how to do perineal? And for all the panelists, if we can keep the answers short, we can get through a lot of questions.
It's a difficult artery to access. And I think what we're most limited by is our ability to visualize it with ultrasound. So again, I think really having that good ultrasound visualization is really, really important. You can't really compress it at the end. So that might be a situation where you would want to snare your wire, get through and through access, be able to advance a balloon from below, or I'm sorry, from above as you pull the sheath, and use that to make sure that you have hemostasis at the end.
Chris, I have
And
a question for you.
question
Sorry.
before we go to the next speaker. We routinely do what you talked about, which is snare and externalize and just try to limit to a 4 French sheath from the foot. But when you're talking about some larger vessels, do you go up to a 5 or 6 and use DCB?
So I'm pretty comfortable doing a 5. I'm not usually comfortable doing a 6 for drug coated. So that's a situation where I would have femoral access and snare the wire and be able to then do the drug coated from an antegrade approach. Although the drug coated balloons are going to be available soon on a smaller platform, smaller profile. So it may give us the opportunity to actually do drug coated technology from the foot, which would be great.
Chris, I had a quick question for you. Thanks for that sort of key overviews of pedal access. Pedal access for me has been like option, D, E. It's kind of a second thought when you can't get anything done. But when is it ever for you option A? It's the first approach.
That's a great question, CJ. So I think, for example, that last patient that I showed, where you have no option to go antegrade, and if it's obesity, if it's a bad groin infection, sometimes if people have fungal infections or things like that, and you still want to stay endo, that would be a situation where I would primarily think about going from the foot, especially if you're thinking about treating below the knee. Radial access, brachial access makes it really difficult to reach distally, and so that gives you the ability to still treat below the knee without having to necessarily navigate a really scarred or bad groin.
Dr. Weger, I actually sorry, keep talking here.
One question, actually, both for you, Dr. Lee, and also Dr. Weger. Both of you talked about plaque morphology, which, actually many years ago when I was down the street, Ken Oriole, Dan Clare, and I looked at using IVUS and used a surrogate algorithm for the coronary package for IVUS to look at plaque morphology and get virtual histology. But still the crux was thrombus. So how can you on luminography help identify thrombus other than maybe the guide wire traversal test? What other tips and tricks do you have? Because that really seems to be an Achilles heel in many interventions.
It's a very good question. I think it's very difficult on luminography to determine thrombus at all. I think it's the wire traversal test is my sort of go-to. And I can't think of many other things other than for sticking an IVUS catheter there. And you can see the different gradation on the echogenicity of that plaque, which it tells you that's a soft thrombus morphology. But a lot of times if you see that kind of gradation on IVUS, where you see a calcified lesion on the surface and you see that mixed signal, you can tell it's probably ruptured plaque, but I think the most relevant information is from the clinical presentation. when you're talking about thrombus or ruptured plaque, it's usually an acute on chronic setting. It's not, chronic ischemia that typically or chronically stable ischemia that presents to you with this mixed, sort of a thrombus burden plaque. It's usually somebody that's been limping along with claudication and then all of a sudden develop acute limb ischemia or some wound that's very abrupt. I think in general sense, clinical information, first of all, lumen, it's wire traversal or IVUS.
I would agree with that totally. I think the clinical scenario, the patient's history, the inciting event, and then let's not forget prior interventions. If you have an intimal hyperplasia, can be that fibroblastic type of disease that someone showed. I'm sorry, I forgot who, a great picture. I think it was you, Dr. Lee, of that intimal hyperplasia that can really cause problems with plain old balloon. Just anticipating that it's present more than we think is also a good idea, as I showed you in my embolic case.
Natalie,
Thank you,
just to
Dr.
follow up on-
Casper.
Oh, so
Yeah,
sorry.
I was just going
Yeah.
to say, Dr. Casper, you want to have the last word and the last question, perhaps?
Well, I don't know about the last word, last question, but it's interesting, and especially in that topic, when you think about SFA occlusive disease, right? Most of the time it starts with a de novo adductor canal lesion, and then that stenosis to the point of occlusion, and then thrombus propagates back, typically to God save the profunda. And thank you, Dr. Lee, for showing us that we probably are emoji deficient in our charting in medical literature. It was a very good visual reference to look at things, and well done. But along those same lines, Dr. Weger, you talked about a lot of that makeup of some of that plaque. And when we look at the most common thing we deal with, which is long segment SFA occlusion, I think a large portion of that, right, is we've learned in our work at Jobst in chronic thrombotic events in the venous system, it ends up being a collagen-based, fibroatherosclerotic lesion. But the true atherosclerotic lesion typically is in a short segment around the adductor canal. Any thoughts on that? Because I think they respond so differently to the different devices we're talking about, whether it's a fibrotic lesion versus something that's either calcified or truly significantly atherosclerotic in a short segment.
I'm sorry, I'm unclear if you were asking me or just the group, but my thoughts and what I read in reviewing for this talk was that maybe some multifaceted treatments might be required. For instance, like uncovering the culprit lesion, like you said, at the adductor canal. And perhaps maybe then the Rotarex wouldn't work for that portion. You can even push it beyond that and not treat that portion that's heavily calcified with that device, and then go ahead and use your directional catheter or directional thrombectomy device or whatever your favorite device is. Maybe you even need to do a smaller intervention of some kind, but it may be a multifaceted approach to deal with this multi-complex problem. Because I think, in my opinion, I've probably underestimated the amount of thrombus and fibrous material whenever I've gotten into trouble. So this talk has reminded me to keep that in mind.
Just another plug for IVUS. I think that was sort of a theme, right? Is trying to pick which device is going to be the best in these patients. And I think IVUS will really show you some of that hard, some of that soft, some of the mobile. So I think not underestimating how effective that can be in helping to guide your therapy.
On that note, I'd like to ask one more question to Dr. Weger. I know you talked about the thrombus burden plaque, and Dr. Casper, you mentioned this. So is there anything, we talked about multimodal therapy. So with the recent COMPASS trial and the Voyager sort of data coming out, does it make sense now then to transition our post atherectomy slash any sort of FEMPOP intervention or infrainguinal intervention, post-intervention, do we put them on Xarelto predominantly to modulate that thrombin and that thrombus formation versus the traditional aspirin Plavix that we've been doing? So what's your thoughts on that?
Currently, I have not jumped yet totally on that bandwagon, but I will put patients on full dose anticoagulation of some kind. If they have what we call like a compromised bypass or poor outflow, or I've had trouble getting them open or had to repeat their endovascular type procedures, and I'm looking at trying to save the limb salvage, not just for claudication. So it depends on their runoff for me still. If they have single vessel runoff, if I am not happy with my repair. In the lady I showed you where I had a problem, is exactly what I did. And it the duplex looked fine in 3 months and I was able to stop it. So for me, I'm still tailoring it. I hope that answers your question, but I'm looking forward to having the answer to some of the difficult problems, or if I suspect a hypercoagulable state, sometimes I'll also check that. Maybe I missed something, that kind of thing. But for now, I have not started putting everyone on full dose anticoagulation, just the high risk, the ones I perceive as high risk.
That's a great segue to probably a future webinar, which is another very controversial topic and something that's ripe for lots of study. Well, on behalf of the Midwest Vascular Surgery Society and my co-moderator, Dr. Casper, I really want to thank all of you. I think the talks were fantastic. The discussion was fantastic. We need, Angela, we got to put this back on the docket for more time next time when we do this. But thank you all. Appreciate your time this evening.
Thank you, everybody.
And big thanks to Becton Dickinson too for their sponsorship, and obviously the Midwest Vascular Society Executive Committee and New Horizons. Thank you all. Thanks, Vic. Good being with you all.